Okay, so as Trevor outlined, my name is Anita Whyte. I'm the Programme Manager for the National Clinical Programme for Dual Diagnosis. And as Liam started at the very outset, the term dual diagnosis is actually a necessary evil. We are working kind of as a part of a health system. From a health...
Yeah, I live in the city centre.
Sorry, folks, I can't mute because while the presentation is on. So if you're not speaking, would you mind muting? Thank you.
Thanks, Tara. So from a point of view of where we're at from a dual diagnosis perspective, we are a health system, and a health system is diagnostic led. So I suppose Liam talked a lot about the social aspects and all of those really, really complex pieces. When we're developing medical models and we're a health system developing structures, it's through the health system to develop it. So it is a necessary evil from a policy perspective and from a point of view of actually developing and delivering programs. So I'll just give you a brief outline as to the National Clinical Programme. It was established initially in 2016 with the first working groups in 2017. That particular clinical programme didn't actually manage to kind of develop the model of care and implement the National Clinical Programme. The timing was good from a perspective of the shift in national policy, because we moved from one mental health policy to another, which actually changed the whole dynamic on what we were trying to achieve. So while at the time it seemed like a really bad thing had happened, it actually now, because we're working with a different policy and a different framework, we're able to do things very, very differently than what the original working group were able to do. So in 2021, in March 2021, I took up my post, and the clinical lead took up his post in June of 2021. I'll be working together with a cross-division, multi-agency national working group for the last over a year to design and develop a model of care to support individuals with a dual diagnosis, or people who are experiencing both mental health and addiction, or addiction issues. It's not just substance, it's actually addiction issues. And we've been working on that since then. April of this year, we had our model of care approved with HSE Chief Clinical Officer. Now it's currently with the College of Psychiatrists, and once the model of care is through that structure, we will be in a position to launch the model, which is a really, really important part in our journey. So just to go through with you what the difference is between the original model of care and the new model of care. So the difference, that shift in policy that Liam alluded to earlier on, has made a really, really dramatic difference for us and for our ability to do what we're trying to do. In the original policy, alcohol wasn't included. It actually is now included from a point of view of policy, and we have included it in our model of care. Behavioural addictions such as gambling, sex, other behavioural addictions are also now included. We've taken advantage of that shift in policy to make sure that we actually are not just focusing on substances, which was the original kind of format of the clinical programme. So we're very different in that sense. Now, the issue around behavioural addictions is because the funding into the health system comes through the Department of Health, which is a drug policy unit. That funding, as Liam again mentioned earlier on, is targeting specific interventions. And we need to change that kind of funding arrangement to enable us to develop and provide supports for behavioural addictions. But it is actually in the model of care, and we have noted it as phase 2 in our implementation stage, because we recognise that while there are substance issues and very significant substance issues among communities, there are also behavioural addictions, and we need to be addressing that as well. The other services that we're working in collaboration with, Liam mentioned again that the need for collaboration, we all, as he said, we all know it. It's actually actioning that and changing culture to enable us to do that is really what's important. So the services we're collaborating with from a point of view of the HSE are maternity services, liaison psychiatry, community drug services, mental health, the broad mental health, because Liam mentioned kind of the different kind of psychiatry pockets on the ground and how they can be resistant to change, as most cultures are resistant to change and most disciplines are resistant to change. But we do need to put a lot of energy into those cross-division relationships. Primary care in the HSE, which is social inclusion, quality improvement division, HSE health and wellbeing, in particular the community alcohol programme, because the community alcohol programme has been set up in tandem with what we're doing. And in actual fact, they should really be working together. So what we're doing through our way of working and our kind of culture shift within the organisation, we're co-locating with community alcohol teams. We're building a network we're doing this ourselves because the system is kind of not necessarily set up in a way that we could do that through a systematic approach. So we're actually doing it on kind of a more localized level. HSE Digital, because I suppose through COVID, we all realized the importance of digital interventions. Digital technologies can really help. Now, I suppose a lot of the people that we may try to help and support, they may have difficulties accessing digital interventions and digital media, but we do have kind of plans and train again in phase 2 to be addressing those kind of interventions and really using the digital interventions that are available to us now. Liam mentioned earlier on the whole concept of culture change and how we can actually really shift and start moving together as kind of different disciplines across different agencies. And a piece of research that he'd actually carried out himself a good number of years ago really identified training and capacity building across partnerships as being a way of shifting culture. So we have embedded that principle in the DNA of the model of care. The model of care is a document. It's a set of, referral pathways. It's an enabler to shift a culture. What we're doing alongside of that is very, very different. And the training and training capacity building piece that we're working on is very much in line with what international best practice would actually suggest and what our own local research and best practice definitely reinforces. The model of care has been designed within the kind of the 9 principles of the Sláinte Care model of cares, which is exactly what we have to do as an organisation. As a statutory body, we must do things a certain way, but in order for us to embed practice, we need to work closer with the community. So what we're trying to do in this clinical programme is adhere to the national frameworks, policies, procedures, everything that we are mandated to do, but use our networks and our culture shift and our relationships to actually do things differently, to try and shift into that cultural move that Liam alluded to earlier on. We're very much operating on a values-based approach, which I suppose really the point with that is if we all at the outset agree what we're trying to achieve, we're all trying to achieve the same thing, whether we're a statutory organisation, whether we're a community, whether we're a government, whether we're politicians, it doesn't really matter. We're all trying to achieve the same thing. We all just have different mandates, different cultures, different responsibilities. So if we come from a values-based approach, we will very quickly realise that actually we identify where we're similar and where we're the same, and then we explore our differences and try and find a way to kind of collaborate and work together to actually kind of address those differences. From a point of view of, back to the whole dual diagnosis piece, and I suppose from a point of view of a dual diagnosis, again, it's back to that very medicalized model kind of way of phrasing things, but that is just the way that we have to present things currently in the current situation. So people who experience mental health and substance use or addictive behavior issues are divided into 2 different sections. They're known as quadrants, so there are 4 different quadrants within the dual diagnosis model. However, they're fundamentally 2 different groups of individuals who need support. One group of individuals are people who would be quite acutely unwell. They would have a lot of very significant mental health issues and very significant addictive issues, and they would be people who we would say would be the ones who need more intensive medical supports. And they would be the individuals that the specialist teams that will be designed or will be implemented, will be kind of introduced into the system. The specialist teams will be a medical team, and they will support the individuals who are quite acutely unwell. However, the difference with this model of care is we endeavour to work with people who are in all quadrants. So it's not just people with diagnosis, it's not just people who need acute care from a specialist team, it's moving into that recovery model. So while the specialist team will support individuals in their acute medical phase, they will also, through integrated care pathways, case management, as Liam alluded to earlier on, and working collaboratively with community and voluntary and other HSE organisations or divisions, will adapt a no wrong door philosophy into the dual diagnosis services. So that's what we are endeavouring to do. We're acknowledging the difference, we're acknowledging the different needs at different phases of people's journeys, and we're acknowledging that the individual who actually has the issues and the individual who's trying to make significant life changes are the people that we need to be listening to. So from a point of view of the individuals who don't need that acute care, how the specialist teams will support those individuals will be through the other healthcare professionals. We'll be building that community in practice through different mechanisms, through kind of introducing case management, through introducing integrated care pathways, all of the stuff that Liam mentioned earlier on. We have all of that included, and we are working towards that culture shift from when the model of care is actually implemented into the mainstream environment of kind of the health system. So just from a point of view of the model of care, the model of care is designed to support adolescents from the age of 10 up to older people to the age of 65. There'll be two different types of specialist team, an adolescent team and an adult team. The specialist team, as I said, will support people who are very acutely unwell, who have significant mental health and addiction issues, and where there is a need for medical intervention. But they will then support these individuals to move out of that medicalized model and into more of a recovery-based psychosocial interagency integrated system through the community and through other voluntary and community organizations. And I'm including the HSE as one of those community organizations, because we need to function on that level as a community organization, not just being a statutory organization. So there'll be other services involved in the integrated care, in ensuring that we do have this continuum of care that we talk about, and making sure that we have the integration, we have the case management. Liam had mentioned earlier on kind of the potential blocks around kind of GDPR. And again, as an organisation, the HSE has an obligation to make sure that this happens. However, we will work in a way with the person who's accessing the services and with their consent, which, as Liam said, people who have issues, they don't really care whether you share their stuff or not, they just want help. So within the case management structure and within a very well established case management structure, we will actually be able to overcome all of those issues with the cooperation and the collaboration and that integrated piece that we're aiming to achieve. We have adapted a PPI approach. That's the public participation and involvement approach to the development, implementation and the evaluation of the clinical programme, which again is very new, because PPI works on the basis that the individuals with the lived experience are those who really are the ones who know what we're talking about. So with the development and the design, we have endeavoured to do, we did a big consultation piece, and the report from that consultation piece is actually contained in the model of care. It's about kind of 20 pages, and it is quite critical of the system and the structure that's set up at the moment, because the information is coming from the people who can't access services. But we're very keen to make sure that the voices of the people who actually need the support are at the fore of everything that we do, as appropriate. And obviously we have to kind of make sure that it is appropriate and it is a way that we're actually, people are comfortable with us, with us working in that way. And it's a huge learning for us. This is new for the organisation. We're working in a way that is very, very new. It's in line with kind of the HRB recommendations. The HSE wants to move this way. It's the way the Department of Health wants to go, but it is a systematic structure change and it's a culture shift. And that actually is not easy. So to even have the principles embedded in any of our practice and in our evaluation and in our kind of our training capacity building pieces is a huge move for the organisation. So that's a really, really positive shift in the direction that we need to be going. And it is going to take a very long time from a point of view of culture shift. But with regards to the specialist teams and the dual diagnosis specialist teams, we are expecting to commence the specialist teams in definitely 2 of the initial site areas at the beginning of 2023, which isn't too far away. It's less than 6 months away, and then we'll be in a position to start evaluating what we're doing and start measuring and start, speaking to kind of the funders and the policymakers around kind of what the benefits are. So there, as I say, we have 3 initial sites identified, 2 adult sites, one adolescent site. The recruitment process has commenced in 2 of those sites. Accommodation has been identified for all of the different specialist teams, well, the 3 different specialist teams. The integration of service is well underway. From a point of view of our initial site areas, one of the kind of conditions of us working with a particular area is that they are prepared to work in this collaborated way, that they're prepared to train their staff together, that they're prepared to work together from an evaluation perspective. We're co-locating with social inclusion, and we're co-locating where we have access to voluntary and community organisations, you know, facilities. We'd be doing kind of outreach into those facilities. So they're all conditions that we need to have in place before we actually will work with a particular area. So the 3 sites we've chosen have agreed to all of that. Now, again, as I say, this is very new and it is going to take time, and it's not going to be a magic wand, but we certainly have all of those pieces mandated, and we have all of those in place before we even start. From a point of view of training and capacity building, we have completed a whole of HSE training and training needs analysis with staff. That has identified what training we need. Again, we're working in collaboration with our partners, statutory and voluntary, to combine what's available, identify gaps and seek to fill those gaps from a point of view of knowledge base. And we have our evaluation framework set up, which will adopt the principles of PPI. So basically we'll have peer researchers evaluating what we do. So the reality of it is the people who need to access the services, who are actually the correct and the biggest critics, will actually be evaluating whether we're doing things the right or the wrong way. So that's really, really important and a really rich piece of work that we're doing. So from a point of view of integration, the specialist team is there. We will be working with, and we are working with, and we're in very, very close contact with all our partners in the HSE, community mental health teams, liaison A&E, Section 39 community projects, drug and alcohol task forces, maternity services, and the prison services. Now, we've the prison services slightly out to the right because we've commenced discussions with the prison services. But until we're in a position that there is actually a medical system inside the prison services that we can act with, kind of liaise with, we're going to have issues, because we obviously can't go in and support people when they're actually in prison. We can support them as they kind of leave, but we can't go in. So that's a piece of work that's kind of, that'll take a bit of time, and that again is in phase 2 of what we're trying to achieve. All of this has been really attributed, the work that we've done has been attributed not to just myself and the clinical lead, because we are one person on 2 days a week. We're not a big team, but we have had a massive amount of support from people in the community, academic partners, HSE, other divisions, who have come with us on this journey, who have actually really, really helped us in everything that we've tried to do. So we set up a large number of kind of subgroups. Some of them have actually done their work, and they've stepped down, and others are continuing, and they will continue with the implementation process. So we're very working very closely with recovery and engagement and consultation groups, both statutory and voluntary. Obviously the training capacity building, again, that's across the different kind of statutory voluntary organisations. Evaluation. We've just embarked on a women's health project, which is to develop a seeking safety model for women in who have substance use and mental health issues and experiencing domestic violence. And we are trying to embed a PPI methodology throughout the whole system. So I suppose in a nutshell, we have our model of care approved by the Chief Clinical Officer. It's currently with the College of Psychiatrists. Initial sites are identified, and recruitment has commenced. Full suite of training and development and framework is now established. And I can't see the one on the right because my screen is blocking me. But oh yeah, it's to say that we will be actually starting our rollout in January, and we will be so. General terms, a model of care and a clinical program takes about 4 years from concept to implementation stage. We're hoping to do that in less than 2, and that is not because we're great. It's because we're working with the community. It's because we're working with our partners, and it's because we're working beyond just the bubble that is the clinical program and the mental health services. So that's my gig.